My name is Bev Gadet. I'm a teaching professor with the Faculty of Nursing at the University of New Brunswick, and I'm joined by Dr. Amanda Benjamin, who's a professor in the Faculty of Education at the University of New Brunswick. We have an incredibly large audience, which speaks to the need of having credible information disseminated about a really important topic impacting many of us, and if not us personally, then and certainly people we care about. Thank you to Dr. Mullaly for redoing this presentation. For those of us, again, who are impacted by this either personally, professionally, and of course, as individuals going through this lovely aging process. I'll also introduce Dr. Mullaly as we continue to work through this. Dr. Mullaly is a general obstetrician gynecologist who practices in the city of Fredericton in New Brunswick since 2005. One thing I certainly appreciate about Dr. Mullaly is her enthusiasm and her passion for her role and the work that she does in our city. She's a clinical assistant professor as well at Memorial University and assistant professor at Dalhousie University. She pursued qualification as a Menopause Society certified practitioner to help women access quality information and care around menopause. Outside of clinical work, Dr. Mullaly plays hockey, which is how I've gotten to know Dr. Mullaly over the years. Some of us are late bloomers, so that's been fun to enjoy with her. She enjoys orienteering, recently started doing improvisational comedy, and she would say badly, but I don't agree. And she also has a pet snake named Bob. So once Dr. Mullaly is ready to get going, that's a little bit of her background, and that will help you appreciate where she's coming from and the lens in which she presents this information to us tonight.
So I'm Christa Mullaly. I'm an OB-GYN. I've met some of you and some of you not. When we thought my camera wasn't going to work, this is a selfie I just took a minute ago of me sitting in my dining room with my family trying to be very quiet in the background while I present. This is a really important topic to me. It became really important about 4 years ago at 1 o'clock in the morning. I woke up roasting, like coated in sweat, soaked pajamas, had to change my pajamas, get back into bed again. And 4 minutes later, I was super soaked again. I was like, what is going on? Is this what menopause is going to be? Am I starting already? And I realized my heated blanket, like I have one of those Costco heated blankets, and you hit it at one click and it turns to 1 and then 2 and then 3 and then 4 and then off. So it was on 1 before I went to bed, and I went click, 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 and was supposed to do 4 clicks to turn it off, and I only did 3. So I had my heated blanket set to incinerate, and I thought, I'm pretty sure this is my, the movies, my sneak preview trailer into menopause. Here we are, and I would say menopause has not disappointed in the hot flash department. So we're going to chat about menopause tonight. I'm super happy to have all these people who are super interested in menopause here. Thank you very, very much. I'm flattered that you're here to listen to me talk because I'm not that interesting, but this topic is super interesting. So we're going to chat about what is menopause, why is it so troublesome. We're going to get into some nerdy grade 9 science stuff. We're going to chat about some interventions that are important, both things that to promote your health through perimenopause and menopause, but also to improve symptoms through menopause. And then I've got some fairly reliable online resources that I can share for information. Here's my inclusivity statement. So while you may see images or information related to women, I actually recognize and support that any issues, therapies I talk about are going to be relevant to any person who experiences menopause and may not identify as a woman. I absolutely honor an individual's right to define their own gender and their pronoun of choice. And I have a land acknowledgement here. So while we're meeting on a virtual platform, I acknowledge the Indigenous peoples of all of the lands that we're on, wherever you may be. I happen to be presenting from the traditional unceded territories of the Wolastoqey peoples. This territory is covered by the Treaties of Peace and Friendship of 1726. For my disclosures and disclaimers, so this presentation is not remunerated. I went to UNB Nursing and said, hey, can you give my presentation a home? And UNB Nursing is a fantastic faculty. They make tons of excellent nurses working in Fredericton and elsewhere. And they really kindly offered us a platform for tonight, and Grant from IT and Bev and Amanda from Nursing and Education have been very helpful. In terms of my disclosures for who has funded me, Astellas is a pharmaceutical company, and I did give a talk to family doctors about a medication that will show up very transiently in 2 slides tonight. one slide. And Bayer Canada paid me to do a talk last year to the nurse practitioners about pain management for gynae procedures. If I was going to be funded by someone for this talk, it would be things like big protein and big yoga and big vitamin D. They're not paying out a lot these days. So this is voluntary because I want people to have good information. And I am a doctor, but I am actually not your doctor. So this presentation is for informational and educational purposes. It doesn't constitute medical advice. Always consult with a licensed healthcare professional for diagnosis, treatment, any other health-related concerns. So let's jump right in. So what is menopause? So we'll start way back with grade 9. What's a period? So let's chat about normal menstrual cycles. They're governed by 4 hormones. So at the start of a menstrual cycle, the brain through the pituitary talks to the ovaries by releasing a hormone called FSH, or follicle stimulating hormone, and says, prepare an egg for launch. And the ovaries, in response to that hormone going through the bloodstream and hitting the ovaries, ripens up some eggs. We start out with over 1 million of them at birth. As those eggs are ripening up, the ovaries making estrogen that talks back to the brain and says, yep, got enough estrogen on board. When there's enough estrogen on board, hitting the brain says, release the kraken, release an egg with a hormone called LH, or luteinizing hormone. If you've ever peed on a stick to see if you were ovulating, you're actually testing for this hormone in your pee. And the ovaries, in response, release an egg. And where the egg was hanging out in the ovary makes some progesterone. That's on a timer, lasts for about 14 days, runs out after 14 days. The lining of the uterus sheds, that's menstruation or a period, and the whole thing starts over again. Most women have about 21 to 35 day cycles. So what's perimenopause? Perimenopause just refers to the time around menopause and refers to the years leading up to the final menstrual period and the first year after the final menstrual period. So the early menopause transition lasts up to several years, and really we see when you start getting occasional symptoms and variable cycle lengths. I call them the accordion period. Sometimes they're further apart, sometimes they're close together, further apart, close together, heavier, lighter. They can be all over the place a little bit, but consistently kind of all over the place. The late menopause transition is the last year to 2 or 3 years before periods stop, when periods start getting further spaced apart, like they're frequently 60 days or more apart. And then the early postmenopausal period, which is considered part of perimenopause, is that first 12 months after the final menstrual period. And of course, we don't know it was your final menstrual period until 12 months have passed. So that's that whole phase of perimenopause. So here's what it actually looks like. The ovaries start acting like surly teenagers at this point in time. So the brain says, prepare an egg for launch, gives that FSH surge, and the ovaries say, maybe, and may or may not behave, may or may not ripen up some eggs. Eventually enough estrogen hits the brain. The brain says, release an egg. And the ovaries again say, maybe I'll think about it. Maybe I'll release 1. Maybe I'll release 2 eggs. And that's why women in their 40s who get pregnant, for example, have a higher risk of twins. And so progesterone surge is, again, unreliable. So because of these variable hormone levels, we also see really variable symptoms. That's why there might be a couple of weeks of, poor sleep or hot flashes and then feeling good for a few months. So the symptoms of menopause during that perimenopause or premenopause, they might be severe, but they're transient. They tend to come and go. Early on in the process, they become more persistent right around that year before the last period and in the year afterwards. And then there's menopause. So menopause is not a disease. All it means is cessation of menstruation, meaning your periods stop, no more periods. The average age is 51. Anything from 45 to 55 is normal. And we spend a third of our lives in menopause. There's very good reason to be invested in being healthy through menopause, because it's a big part of our existence. And it's experienced differently by all women. Women experience menopause in very, very different ways. So no 2 experiences are the same. And up to 25% of women are no flashers. Approximately 1% of women in this presentation probably. But up to 25% of women just have periods and then they stop having periods. So in menopause, there are no good eggs left in the ovaries. So brain talks to the ovary, says, prepare an egg for launch. And the ovaries say nothing. They have no response to that, right? They're not making any eggs. The eggs are all gone. The brain yells a little louder, prepare an egg for launch. The ovaries, fresh out of eggs. They're not doing anything. The brain launches even more hormone, FSH, LH. The ovaries, they've got no response to that. So menstruation stops. The pituitary hormones go up, right? So FSH and LH on blood tests go up. The ovarian hormones, though, progesterone, estrogen, go down. And it's those shifts and transitions in hormones that cause hot flashes for women, or vasomotor symptoms, night sweats, and a lot of the other symptoms. And there's an eventual adaptation to that. In terms of what is a hot flash, so this is what the brain normally looks like in managing thermoregulation or temperature control. So there's a center in the hypothalamus in your brain called the thermoregulatory center. It controls the thermostat, make you hotter, make you colder, this is too hot, this is too cold. It's influenced by the environment, activity, exercise, ambient temperature, but it's also influenced by these neurons called candy neurons. So those are nerve cells that input directly into the thermoregulatory center and say too hot, too cold. Normally, they're kept in balance by two things. There's lots of other factors, but these are the two big ones. Estrogen has an inhibitory factor. So estrogen turns down the temperature and says, no, we're fine. We're not too hot. We're all good. And then there's this neurokinin B stuff. It's red and angry looking because it says, whoa, holy cow, heat stroke. We're too hot. You need to dump heat. And normally these two things are in harmony. This is an adaptation of a nice little diagram from Jen Gunter. But if you take the estrogen away, you've got no estrogen here, like we see in perimenopause, or decreasing levels of estrogen. And so those candy neurons don't get the estrogen turning down the temperature. The call is coming from inside the house, right? Neurokinin B hits those candy neurons, nerve cells, unopposed. And so those candy neurons occasionally will send these giant signals to the thermoregulatory center saying, you are about to have a stroke because you are so hot. And that's when a hot flash happens. The body responds to that by dilating all your blood vessels. The skin heats up. You may sweat, but the core temperature often drops. And that's why some women have a hot flash and then feel cold afterwards, because there's been this heat dump and your core temperature decreases. So transitioning to what that actually looks like or how that actually happens, here are the rails. Before menopause, estrogen levels stay between the rails. They fluctuate in a nice cyclic or semi-cyclic pattern for most people. And then when we get into perimenopause, estrogen can go both ways. Occasionally, there are going to be these big surges in estrogen. That's why some women say who have really estrogen-sensitive migraines get worse migraines in perimenopause. And there are these big drops. And it's a combination of those quick transitions and the extremes that lead to fluctuating hormones, hot flashes, night sweats. And then eventually, after menopause, after the final menstrual period, there's this period of adaptation where eventually some symptoms settle. Lots of women continue to have occasional hot flashes into their 60s or even 70s, but the severity usually decreases after the early to mid 50s. I included this diagram because it shows why blood tests are really challenging for trying to assess this, or saliva tests, any kind of testing we try to do. So this top line shows the 4 different hormones: estrogen, progesterone, FSH, LH, and how they vary in an average woman over the course of 6 months. And although they're varying, you see they follow these nice predictable patterns. It looks like the pattern you'd crochet on the bottom of a sweater. In a woman who is perimenopausal over a 6-month period, these hormones are all over the place. So estrogen is up, estrogen is down, progesterone is up, progesterone is down, FSH is up, and then it's down, and then it's up again, LH, same thing. And so if you take a blood test or a saliva test at any one point in time, that's not predictive of what's happening at other points in time. And that's why for most women, like if you're having hot flashes and your periods are wonky, probably I don't need a blood test to tell me you're in perimenopause if you're 47 years old. There are certain situations where lab tests can be helpful, but not most of the time. And then, of course, after menopause, we get back to a steady state again, and that's what the body adapts to. We're going to move on to chatting about what those hormones are. So there's estrogen. It's the main female hormone. It comes in 3 forms. There's estradiol, which is the most active one before menopause. There's estrone, which is a weak one, and it's more active after menopause. And estriol gets a lot of press, but it actually is the weakest of these. It's mostly involved in sustaining pregnancy, but its biologic activity is just over 1% of what you see with estradiol. The levels overall of estrogen drop by about 2/3 in menopause. And so it's not a surprise women get all these symptoms because there are receptors for estrogen in over 400 body sites: skin, bone, muscles, heart, reproductive organs, bladder, breast, blood vessels, brain, everywhere we have estrogen receptors. And you can see menopausal effects at any of those sites. Progesterone is the other main female hormone. It opposes estrogen. It keeps the lining of the uterus from overgrowing. It helps to prepare for and sustain pregnancy. It has really different effects in different women. For some women, it can be very calming. For some women, it acts as a depressant. And then testosterone is the last of the main hormones we talk about. Women have testosterone too, although at much lower levels than men have. Testosterone is important for muscle and bone mass. It helps for some people with a sense of well-being and mood. It can drive libido. It's made in the ovaries and the adrenal glands. Those are little glands that sit on top of your kidneys. It slowly declines throughout adulthood. So it peaks late teens, early 20s, and it drops by about 50%, just in a slow, gradual fashion from age 21 to age 50, about half of what it's going to be, and then it continues to drop slowly. There isn't a sudden big change in testosterone production during menopause. Because of the effect of estrogen on the protein that binds testosterone, some women see this transient increase in their free testosterone. That's why we grow our beautiful beards and mustaches as we get through menopause, but that's also why some women get this bump in sex drive through perimenopause. So, I mean, there's no denying that menopause symptoms suck and they can occur everywhere. Not all symptoms in menopause are hormone related or hormone caused, but many of them can be made worse by the menopausal hormone changes. The big ones we think about with menopause that are very driven by hormones are vasomotor symptoms, so that's hot flashes, night sweats, sleep disruption, which can occur independent of hot flashes, mood symptoms, so that depression and anxiety. Then there's lots of other stuff. Cognitive changes, brain fog sounds familiar to lots of people, changes in sexual desire and function, pain with sex and sensitivity, urogenital, meaning bladder, vagina, vulva, uterus changes, so changes in periods, sometimes like things like vaginal dryness, vulvar itching, burning, bladder symptoms, having to pee a lot, having to go when you got to go, sometimes bladder infections. There's these what are called integumentary changes, which just refers to your skin and any moist surfaces and hair changes. So the skin becomes less thick, less elastic, less hydrated, it wrinkles. Sometimes we see hair loss, dry eyes, very common in perimenopausal women. There can be weight and metabolic changes. So interestingly, women have their greatest weight gain in their 20s and 30s, but in menopause, we see this massive redistribution. So there's that increase in visceral fat and waist circumference. We kind of have that spare tire around the middle. And that's a redistribution effect more than a necessarily a weight gain effect, because we continue to gain weight throughout our lives. And the musculoskeletal system, we don't talk about it as much. Joint pain, very common through perimenopause and menopause. Bone loss, most people are fairly aware of. Muscle loss is a big one that we don't talk much about also, but sarcopenia or muscle loss is a major issue, and we'll chat a little bit more about that later. So you can see why women find they struggle with all different types of symptoms through menopause. So that was all super inspiring. But at this point, we're going to move towards things we can do for a healthier menopause. So there's two issues I'm going to talk about. First is going to be healthy habits and nutrition, how to set people up for the best possible health, protect your bones, your brain, your heart as much as possible. Then we're going to chat a bit about surviving the symptoms, particularly that trifecta of doom, right? The hot flashes, the sleep problems, the mood problems, but also we'll address the sexual changes, vaginal dryness, brain fog. First healthy habit we're going to chat about is managing stress. Everybody's familiar with the sensation of being stressed out at different points in their life. That really tends to crescendo, though, around late 40s, early 50s, for hormonal and other reasons. We hear lots of terms around this. There's things like stressed out, burned out, midlife crisis, adrenal fatigue, struggling with work-life balance. We're certainly, for many people, in the sandwich era of looking after older parents and kids, especially when teenagers hit the teen years around the time of menopause. We have acute or sudden or short-term stressors on top of all of the chronic stressors we're trying to manage. We know that stress isn't healthy for us, but there are actually physical effects from it. It can increase the risk of heart disease, metabolic syndrome, which just refers to that triad of diabetes and high blood pressure and high lipids or high cholesterol. Chronic stress is associated with an increased risk of things like obesity and depression, which is not a surprise. But there is actually scientific evidence for things that can be done to help manage stress. So there's excellent scientific evidence to the benefits of stress from things like time in nature. Spending 20 minutes in nature reduces cortisol measurably. And that doesn't mean standing in your backyard listening to the street go by, but good evidence for being surrounded by nature, beach, water, forest, trails, things like that is good for reducing cortisol levels. Things like spending 90 minutes in nature at least once a week has appreciable measurable effects on stress and health measures. Mindfulness programs, incredibly effective. People are really familiar with the most common of that would be yoga, lots of yoga around, but there's something called mindfulness-based stress reduction. It's offered in Fredericton through the Brookside Wellness Center. UMB does MBSR courses or clinics, at least on their website it says they do. And that's a mindfulness base. So mindfulness refers to being present and aware of the time and space you're in and your body in that space. Cultivating social supports is very important. The reason why you feel so good after going on a road trip with the girls or spending time with family or loved ones is because those things appreciably reduce stress and help to improve, again, all of those physiologic measures of wellness. Therapy, the value of therapy can't be understated. Cognitive behavioral therapy, there's other forms of therapy. And of course, and you'll hear me harp on this, adequate sleep, adequate nutrition, physical activity. My challenge, if you're listening in or watching, is for you to spend 20 minutes this week doing something that is stress modifying in an intentional way. So either in nature or doing yoga. 20 minutes, not 20 minutes every day, just 20 minutes once of doing something that will reduce stress. Next healthy habit is exercise. Exercise doesn't improve hot flashes, sorry, but it's good for almost every other part of your health. It reduces risk of death, disability, chronic disease, cancer, heart disease, bone fractures. It improves things like blood pressure, blood sugars, mood, and sleep. This is a guideline from the States. The Canadian one is similar. I just like the way this one was laid out a little bit better. Mainly because it emphasizes the idea that every bit helps. So although the goal is 150 minutes or more of moderate activity per week, that means 30 minutes, 5 days a week. It can feel really defeatist to feel like, well, if I can't get all that, it's not worthwhile at all. And I like how the U.S. physical activity guidelines emphasize this idea that every bit of activity you do is helpful. Don't set a goal of doing 150 minutes a week. Set a goal of walking around the block. You can combine being social with exercise. If you can find some girls to go walking with. This is one of my big things for healthy habits, which is this is my mom hockey group that I play with on Wednesday nights. There are other things that are recommended. Strength training of major muscle groups 2 to 3 times per week. That helps with that muscle loss that we see through menopause, perimenopause, and balance and mind-body exercises. So yoga, Tai Chi, martial arts, any of those, particularly for midlife and older adults, 2 to 3 times a week improves balance and stability, particularly when we think about the increased risk of falls and fractures with aging. I just got a text from Anna to slow down. I'm going to try really hard. Keep reminding me though. Next healthy habit, preventive health screening. This is a pretty easy one to stay on top of. If you know how to do it, make time to make appointments to get stuff done. There are 3 major cancers that we see in women that can be screened for. What screening means is if you can detect a disease in its early stages or before it becomes a cancer, then you can change the course of that disease and lower the risk of it being more advanced at time of dissection or making it easier to treat. So mammograms to decrease the risk of breast cancer. In New Brunswick, it's recommended that all women aged 50 and over undergo regular mammogram screening. There are other societies that recommend starting earlier. And so, in fact, in New Brunswick, women may self-refer to have screening anytime from age 40 and beyond. You don't need a referral from your family doctor for that. If you happen to live in the Fredericton-Oromocto area, you can call the Oromocto Hospital to self-schedule a mammogram. And they schedule quite a ways out, but it's a screening test. So if it takes 6 months or longer to get a mammogram, you're still getting booked for that test. Colon cancer screening is the next one. So for your 50th birthday, if you have a valid New Brunswick Medicare card, the province will send you a present. And the present they will send you in the mail is a poop testing kit. It's a fecal immunohistochemistry test as a screen for colon cancer. And your present to yourself is you get to send your poop back to the government for your 50th birthday. And then if you screen in or as being higher risk, then you get extra testing done. And the last one is cervical cancer screening or PAP tests. Depending on risk history in New Brunswick, currently PAPs are being done every 1 to 3 years. Over the next few years, we're going to see HPV testing phased in. You may have heard about that. So that'll be every 3 to 5 years, depending. But for now, we still have conventional or old-fashioned PAPs done every 1 to 3 years. For women who don't have a family physician or a primary care provider or a nurse practitioner, on the New Brunswick, Government of New Brunswick Health website, they have information about cancer prevention and screening. Or if you go to the Horizon or Vitalite websites, you can search on there to find local PAP clinics near you. Next one is healthy nutrition and talking about bone health. So we know that about half of women will get an osteoporotic fracture at some point during their life. We lose about 30% of our bone mass by age 80. We know that supplementing calcium and vitamin D to make sure you have adequate levels does reduce bone loss after menopause. Ideally, nutrients come from dietary sources if possible, but lots of people need to supplement to get what they need. For vitamin D, it's actually really hard to get an unfortified dietary sources. So deficiency is really common. In the winter months, 13% of us have frank vitamin D deficiency, and a large portion more have insufficiently or low levels. Vitamin D is important not just for bones; it's good for your immune system, your brain, your kidneys. Depression or deficiency can be associated with a higher risk of depression and joint pain, and maybe some cancers. And so you should have as a baseline at least 600 to 1,000 units a day, up to 2,500 units a day, potentially in some situations. But the baseline would be 600 to 1,000 recommended. Calcium and magnesium are both considered something called shortfall nutrients, and they're both important for bone maintenance. Magnesium is a cofactor for lots of enzymes and other things in the body also. But being a shortfall nutrient means that over half of women in North America aren't getting enough calcium and vitamin D in their diet. For women under age 50, 1,000 milligrams a day. Over age 50, 1,200 milligrams per day. The typical calcium-rich serving has about 300 milligrams in it. For example, like a cup of milk. So 3 to 4 servings a day is what's necessary for most women. For magnesium, like a typical serving has like 60 or 80 milligrams. So it can be a little tougher to get enough servings to get magnesium from your diet. And of course, weight-bearing exercise, also really important for bone health. So those are things that are important to keep on top of to promote the maintenance of bone and slow that loss of bone over time. And then muscle mass. I know I keep coming back to muscle, but muscle loss is as important as bone loss. And in fact, during the menopausal transition, we lose a higher proportion or higher percentage of our muscle than we lose of our bone, up to 10% of our muscle mass. In order to maintain muscle mass, of course, exercise is important, or being active. But in terms of dietary intake or nutritional intake, at least 20% of your calories should come from protein. Approximately 1 gram per kilo per day, 1 to 1.2 grams for people who are athletes. We're doing a lot of weight training. There may be a higher need for protein. But for a typical 180-pound woman, that works out to about 80 grams per day. It's recommended that half of that come from plant sources if possible, which can be tricky to achieve. But it definitely should be spread out through the day. So having a protein source at breakfast helps to set up your body throughout the day, both in terms of satiety or your sense of hunger, but also in terms of having that constant amino acid protein supply. My challenge, and anyone who's ever seen me as a patient has heard this, is I tell perimenopausal women to track their protein intake for 40 hours, even just 24 hours, to see, because most women aren't getting enough protein in their diets. You can use Google to help you figure out how much protein is in foods and track it, both how it's spread out during the day and how many grams you get, to figure out if you're getting enough. That's all the nutrition stuff. I know that's not very sexy stuff, right? Telling people to exercise, manage their stress, but it's so important for our health before we can get into specifically managing symptoms. We're going to talk about managing menopause symptoms. In terms of what people choose for management, it really is person specific. So there's no one size fits all strategy for managing menopause, right? Everyone should choose the right option for them. And that involves reviewing all of the information that's available and high quality information, considering what symptoms you have, how severe they are, your own health history, your risk factors, your lifestyle, and weighing risks and benefits of different therapies and options, either taking them or not taking them, and considering what your personal beliefs and values are. There's great information at these particular 4 sites, and I'll put them up at the end of my last slide again. The Menopause Quick 6 Canada was designed by a family doctor in Canada to make excellent primary care resources available for physicians and nurse practitioners, but there is a for women or patient information section to the site that has some helpful handouts and brochures. Menopause and You is the Society of OB-GYNs of Canada website that's specifically with menopause information. The Canadian Menopause Society is kind of a low budget website. It takes a while to navigate through, but if you can find the menopause information for patients on it, it's actually pretty good. And then the Menopause Society, formerly the North American Menopause Society, based out of the US, they have a website that's really mostly geared towards clinicians. If you can navigate through to find the patient information, I don't find it particularly comprehensive, but the stuff they have is very good if you can find it. So we're going to chat about managing specific symptoms. We're going to talk about vasomotor symptoms. So remember, that's the hot flashes, night sweats, sleep disruption, mood disturbance, and then the genital, the bladder, the sexual symptoms, and finally the brain fog and cognitive changes and challenges that can come through menopause. So we'll start out with hot flashes, night sweats, or vasomotor symptoms. So the general framework for how we think of this in terms of what the Menopause Society says is we think about medications and non-hormonal or non-medication actually options for managing symptoms. There's in the medication, there's hormone therapies, but there's also non-hormone prescriptions that many women find helpful. In the non-medication options, there's lifestyle changes, mind-body techniques, maybe some other new interventions and things on the horizon. In terms of why, you'll hear physicians and nurse practitioners giving the recommendations we do about why do we seem to keep talking about hormones. It's because the Society of OB-GYNs of Canada has clinical practice guidelines. So these are the guidelines we refer to help us know what the standard of care is or how we should be treating different medical conditions. So the management of vasomotor symptoms, there's a guideline from 2021 that has strong recommendations based on a high grade or high quality scientific evidence that we use. And I'm not going to read every word here, but the gist here is that healthcare providers should offer menopausal hormone therapy as the most effective option for managing vasomotor symptoms. So for women who are younger than 60 or less than 10 years postmenopause who don't have contraindications or reasons why medically they can't or shouldn't take hormones, but that of course we need to consider medical history, treatment goals, patient preference, and then think about how long do we want to stay on therapy. For women who are under 45 years of age when they stop having periods or go through menopause, then certainly it's recommended to do some type of hormone replacement until age 50 to protect the bones and the heart. They give some suggestions about what specific agents we should use. So estrogen and progesterone together for menopausal women, and for perimenopausal women, different formulations, including IUDs, birth control pills, things like that. There are non-hormonal prescriptions, and they can be considered when menopausal hormone therapy is either contraindicated, so medical reasons why women can't take it, or for women who would rather not be on hormones. It's their preference not to take anything hormonal. And of course, there are also cultural therapies and cultural beliefs and practices around menopause that are important to respect. In terms of why we get on about hormones, I really like this graph because, I mean, it's one of the old ones. It's over 20 years old when this study was done, looking at how women responded in terms of hot flashes being on systemic estrogen. So for women having 70 hot flashes per week or more who were put on different doses of estrogen, we see a significant decrease in hot flashes within a month. Most of the, especially at the two higher doses, where women were having half as few hot flashes or half as many hot flashes or fewer. And by the time we get out to 12 weeks, I mean, women in the highest dose group were having more than 90, highest two dose groups were having more than 90% fewer hot flashes. So we know that estrogen is really effective. But there's a gray line on this diagram that's really, really important too. And the gray line is women who are on placebo. Would feel like getting ripped off if you were going to the study for your terrible menopausal symptoms and you realized you got the placebo or the sugar pills afterwards. But in fact, on average, for women who were on placebo at 12 weeks, they were having half as many hot flashes as they started with also. This is an interesting consideration. We'll come back to it after. But what it really means, or what it really says, is that if something is working for you and it is safe and not dangerous, then it's working for you. So don't stop something because I say in a slide, there's evidence this isn't better than placebo, because if it's working for you, it's working for you. If it's healthy, keep doing it. Some people wonder why there's all this controversy, right? Because for 20 years, it felt like every time you'd ask someone about hormone replacement, they'd say, no, hormone replacement is terrible. It's bad for people. It causes cancer. And this all came out of when I was in my training in the early 2000s, the Women's Health Initiative was published. So we're just going to get into a bit of nerdy epidemiology here, but to understand the background on this, it's a really well-intentioned study that kind of went off the rails a little. So they took 26,000 healthy women who were aged 50 to 79 of an average age of 63. So on average, they were 10 or more years past menopause, and gave them either placebo pills or hormones, estrogen and progesterone if they had a uterus. And their question was, if we put healthy women on hormones, can we decrease their chance of dying of heart attacks? That's a great question. And they followed for 5 to 6 years, and they stopped because they saw an increase in breast cancer, and also trend towards increased blood clots and cardiac events in the women who were on estrogen and progesterone. So they stopped a little bit early. Because they saw increased complications. So the moral of the story is you shouldn't take like grandma who's 79 years old, who has no symptoms of menopause, who's living her best life, and try to lower her risk of having a heart attack by putting her on estrogen. That part of the study makes sense. Unfortunately, what, of course, the media and often in general, the medical community hears from that is, oh my gosh, don't put women on hormones because it gives them heart attacks. And the truth is actually quite a bit more subtle than that. So when you pull out the data and you look at the trends for women who are aged 50 to 59 in the study, so those early postmenopause women, in the estrogen-only group, there was actually a very small decrease in heart attacks, diabetes, cancer, and death in the hormone group compared to the placebo group. There was a significant decrease in fractures in that group, but there was a very small increase in blood clots. And over the course of 10,000 women, we're talking like 5 women or so. In the women who are on estrogen and a progesterone type medication or a progestogen, there was a very small decrease in the risk of diabetes and death overall. There was a decrease in fracture, but there was a very small increase, again, on the order of 5-ish, 5 to 10 in some cases, per 10,000 women, increased risk of heart attacks, strokes, blood clots, and breast cancer. So overall, over 10,000 women, the risks and benefits per year were very, very tiny. The hormone selection also was a little different from what we use today. They used oral estrogens, conjugated equine estrogens, not super commonly used today, and redoxyprogesterone acetate. Again, it's not a natural progesterone, it's a progestogen, and we don't use that typically as our first line these days either. The ones we use now might have a little bit lower risks, but the moral of the story is we shouldn't put all women on hormones to try to make them healthier. But that doesn't mean that for women who have symptoms that we shouldn't put them on hormones, because we know that if you put them on hormones, the risks that you may increase for them are actually very small in absolute terms. And for the super visual people, don't try to get too into this graph. It's kind of very, very busy. But this just shows the things in red are the increase and the things in blue are the improvements in risk scores for women who are on estrogen. They had a few more bad things happen and a few more good things happen to them. For women who are on estrogen and progesterone, they had more in terms of strokes and heart attacks, about 5 per 10,000, even though they had a decrease in fractures. But again, these are such small numbers over 10,000 women that, again, we don't put women on hormones to try to give them a better heart or to try to give them a lower risk of diabetes. But it also doesn't mean that we shouldn't put women on hormones if they have symptoms, because we know that the absolute risks are pretty small. So who can take menopausal hormone therapy? So coming back to the guidelines, so women who have vasomotor symptoms, hot flashes, night sweats that affect their quality of life, who are under age 60 or less than 10 years from their final menstrual period, are women who are candidates for menopausal hormone therapy if they don't have a history of blood clots in the legs or the lungs, of stroke, of coronary artery disease, meaning angina or prior heart attack, women who don't have a breast cancer or an estrogen-dependent cancer, who don't have undiagnosed abnormal vaginal bleeding that needs to be investigated, and women who don't have active liver disease. And in fact, menopausal hormone therapy, or hormone, in this case, replacement therapy, is recommended for women who have early menopause under the age of 45. In terms of the hormone therapy options that we offer, there's sort of three main recipes that we use. One is estrogen systemic therapy. What I mean by systemic is it's something that you either take as a pill or as a gel that you rub on your skin or a patch that you put on your skin that goes through your bloodstream and affects the whole body. Women can go on estrogen by itself if they don't have a uterus. For women who have a uterus, and some women even without a uterus find it helpful, they can take estrogen with a progestogen or a progesterone type medication with it. And progesterone comes in lots of different versions. It comes as a pill. If you've ever heard of a Mirena IUD, that's a progestogen containing intrauterine system or IUD that sits inside the uterus and protects the lining of the uterus. For some women, birth control pills are a good option for perimenopausal women who are still having periods. So there's lots of ways to deliver estrogen and progesterone to women. And then finally, although it's technically off-label, for some women, they take a progesterone only, particularly for women who can't take an estrogen. There are cases in which a progestogen may help with things like sleep and sometimes with night sweats and hot flashes. There's some other formulations that I'm not going to get into, like tissue selective estrogen complexes, bazodoxifene, and things like that. But those have select specific situations we would use them for that are a little beyond this talk. And then there's non-hormonal medications. So the Menopause Society, formerly called NAMS, put out a really nice summary table that I really just lifted and plastered because I thought it was really good, talking about the 4 main medications that we can use that are non-hormonal to help with menopausal symptoms. Although the first 3 are technically considered off-label, they're certainly all supported by our guidelines. So SSRI and SNRI medications are known as antidepressant and anti-anxiety medications. Depending on the medication, they can have mild to moderate improvements both in severity and in frequency of vasomotor symptoms. They can also help sleep and mood and that sense of well-being. Probably the best study for this is venlafaxine, also called Effexor, you might have heard of, or escitalopram. Main side effects we see in some women with SSRIs and SNRI medications are things like nausea and sedation, but these are medications that tend to be really well tolerated. For women who have predominantly mood symptoms in menopause without as severe of the vasomotor symptoms, this can be a good class of medications that women might want to try. Gabapentin is a medication that can be used often for chronic pain. It certainly can improve both the frequency and the severity of vasomotor symptoms. Uncertain about sleep. Nobody really knows the mechanism of how it works. For side effects, it tends to have sedation, dizziness as a side effect. Coming off of it can sometimes cause withdrawal symptoms. Gabapentin is a really good medication for chronic pain. So for women who may be dealing with chronic pain and also vasomotor symptoms, gabapentin may be an option there. Not typically a first line we reach for, but it's certainly one of the tools in the box. Oxybutynin similarly is not a commonly reached for one, but can be helpful. You may have heard of it because it can be used for overactive bladder. It does reduce the number of moderate to severe vasomotor symptoms. For side effects, it can drop the blood pressure a little bit. So someone get a bit of dizziness and a really bad dry mouth with it. It can cause urinary retention. That's not a common side effect, but it's that effect on the bladder that helps with overactive bladder symptoms. So for women who have a little bit of overactive bladder or have a lot of overactive bladder symptoms and a little bit of menopause symptoms, sometimes oxybutynin is something women consider in that situation. We don't love it for older adults, both because of the dizziness and possible increased risk of falls, and there may be a bit of cognitive decline with it. And the last one on the list is actually not off-label. It is now on-label. Fezolinetant, it's called. It's a new central acting medication, meaning if you remember the box in the brain with the hypothalamus and the thermoregulatory system, it actually works in there to decrease the signals. And it's approved specifically for vasomotor symptoms. It has been in the States for a couple of years now. It's literally just arrived in Canada within the last 6 weeks or so. So I don't know how it works yet for my patients because I only have a couple of people or a few people who've just started on it or are waiting to start on it. What I hear when I've been to meetings in the States and talk to colleagues is they really like it there, but we'll see how it goes. For side effects, it can have some belly pain and some diarrhea, GI side effects that are common with lots of medications. There may be some reports of changes in liver testing, although not severe changes, but women need to do some surveillance blood work when they start on it to check their liver tests. So that's the end of the medications. We'll talk about some non-prescription things. So there's good evidence for a number of things for hot flashes and night sweats. Cognitive behavioral therapy. Why and how therapy works to help with hot flashes and night sweats, I can't explain that. Back to the gray line on the placebo. But we know cognitive behavioral therapy is better than placebo for vasomotor symptoms. Mindfulness-based stress reduction, that mindfulness stuff, clinical hypnosis, dietary things, there's mixed evidence and probably emerging evidence on things like a higher soy or plant-based diet, and also a lower glycemic index diet. Both of these things are healthy for you anyway. It's unclear about supplements, B vitamins, vitamin E, about whether they may be beneficial for some people also. Again, if it works for you, it works for you. A stellate ganglion block is actually a nerve block in the neck for people with chronic migraines, and it shows some promise from one little study potentially for vasomotor symptoms. Stay tuned. We don't know that much about that yet. And then there are things that are recommended by places like the Menopause Society that don't have clear evidence one way or the other, but we recommend them anyway. This is like that menopause starter kit that I recommend to women, right? You need a fan and you need a sweater so you can go back and forth between them. Things like avoid your triggers, do cooling techniques, dress in layers, take layers off if you need to, use fans, cold packs on your neck, whatever you need to use, and definitely decreasing smoking and alcohol, both of which can be triggers for hot flashes and night sweats. And then there's evidence for things that have been studied against placebo and have been shown to be not better than placebo. But remember, placebos work pretty well. So if any of these things is working for you, keep doing it, because if it doesn't work better than placebo, it's probably still working for you, especially for you. So exercise doesn't help hot flashes and night sweats, but it's still really good for you. Yoga, not going to help hot flashes or night sweats, but it's good for stress, and it's also good for that balance and stability stuff. Paced breathing exercises, acupuncture, and these are supplements and medications listed here that have been studied against placebo and have been shown to be not any better than placebo. So we've got omega-3s, black cohosh, dong quai, evening primrose, flaxseed, some others. DHEA got really popular in the press in recent years, but it was looked at in a really nice study versus placebo for a whole bunch of menopausal symptoms and wasn't better than placebo. With the exception of for women who have lupus, there may be a role for DHEA. That's a discussion to have with your own physician or nurse practitioner, though. So that's enough for vasomotor symptoms. We're going to sleep or a lack thereof. So sleep's really important. It can be very hard to get. I can't believe I'm here preaching to people about sleep. I'm not one of the people who gets enough sleep. I'm in the 35% of adults who don't get enough sleep at night. So I know I've been saying all these preachy things this whole presentation about like exercise and stress management and sleep so that we're really, really clear. I am terrible at all of these. So don't be like me, just be more like the things I'm talking about. So at least 35% of adults don't get enough sleep. You are not alone if you're not getting enough sleep, but it is recommended to try to get at least 7 hours a night. We know that getting inadequate sleep, particularly less than 6 hours a night, can be associated with things like emotional instability, definitely impaired cognitive function, impaired glucose metabolism. That means running higher blood sugars or more abnormal blood sugars, and increases the risk of high blood pressure, obesity, and all-cause mortality. And of course, sleep apnea is another consideration in there. So you should talk to your doctor, your nurse practitioner, if you have excessive daytime sleepiness, heavy snoring, other risk factors or signs of sleep apnea. The short, thick neck is the body type that goes along with it. Women who struggle with obesity and carry a lot of weight around their neck, for example, but also if there's a strong family history. So if you're not sure, talk to someone about getting a sleep assessment. This is a really busy slide, but Rebecca Robbins is a sleep doctor in the States who came out with an excellent guideline last August about how to optimize sleep, recognizing the fact that people don't get enough sleep. I'm not going to read this whole entire slide. It's a good one to screenshot if you want to. But it's simple recommendation, but recommendations that do have some evidence for them. Things like maintain a consistent schedule. If you're going to nap, napping earlier in the day and for a shorter period of time is better than later in the day or longer naps. Limiting caffeine after lunch because it can stick around for 6 hours or longer and act as a stimulant. Limiting alcohol. So alcohol is sedating, so it seems like it might help sleep, but it actually really messes with sleep architecture, meaning trying to get restful sleep. Avoiding nicotine because nicotine can be a stimulant. Exercise, particularly earlier in the day. Having a dark, quiet room, sleep-inducing environment. Removing bright alarm clocks. For those who are children of the 80s and 90s, we all remember like that alarm clock that was like having a red beacon in the room because of like the boxy numbers in them shining. Avoiding meals right before bedtime, but eating a healthy meal, 1.5, 2, 3, 4 hours before bed may be helpful. And avoiding bright screens and TV close to bedtime because bright lights, right? Or blue light, which is what is in most of our screens, sends an alert, its morning signal to the brain. So I know we all want to doom scroll at bedtime, but it's actually healthy to put down a book instead. And that's where we come to, not quite to my next challenge, but we'll come to that. In terms of what works for sleep, so there's a great study called the Ms. Flash study, which is a huge, what's called a network or a scattershot study that was done in the States where they took 1,500 or 2,000 women, they divided them in a whole bunch of groups, 150, 200 women in a group, and tried a whole bunch of different things for them with their menopause symptoms to see what would work. It was the menopause strategy, finding lasting answers for symptoms and health. And so for the sleep arm of this, they look to see what's going to work. So this is kind of a hard diagram to read, but you can see here, omega-3s aren't going to help sleep. This score on this axis is the insomnia score. So higher is worse, lower is better. And after 12 weeks of omega-3, women weren't sleeping better from the omega-3s. Yoga was maybe helping sleep a bit. Exercise was helping a bit. Estrogen in this group was helping a bit. Escitalopram seemed to help a lot at the beginning, but then I don't know what happened that it rebounded. Venlafaxine was pretty promising. And then this group of women in the pink group, they had a huge improvement in their sleep. And this has been seen across multiple studies. I saw Catherine Guthrie, who published this, speak about sleep last year in Chicago. This is cognitive behavioral therapy for insomnia. It is incredibly effective for sleep. People hear cognitive behavioral therapy and they think like someone's going to talk to them about their childhood. That's not what CBTI or cognitive behavioral therapy for insomnia is. It's a 5 or 6 session program that reviews or explores things like attitudes and behaviors around sleep, healthy sleep habits, triggers, responses, and it has excellent efficacy. If you happen to be a therapist and you happen to be listening to this presentation and you want to get certified in CBTI, please let me know if you get certified because I have lots of women who would love to see you. For now, if you're trying to access CBTI, though, they're actually excellent and very effective online resources. Dalhousie University, in combination with Sleepwell, which is a group out of Halifax, has an excellent website, mysleepwell.ca. And they have a huge section on their website about CBTI or cognitive behavioral therapy for insomnia, including links to things like workbooks, apps, online therapy access, many of which are free, some of which come with a fee. But if sleep is a major issue, CBTI is recommended for every perimenopausal woman who is struggling with sleep, along with other strategies. My challenge for everyone watching and for me too, because I'm terrible for this, is to sleep without your phone by your bed for one night. And that doesn't mean like put it in the other room right before you go to sleep. It means put the phone away an hour or two before bed so you don't have access to the blue light or exposure to the blue light and just the mental stimulation of it. Read a book, do something else, but leave your phone somewhere else for one night and see if it improves your falling asleep, staying asleep, especially because there's nothing there to look at 3 o'clock in the morning if you happen to wake up. That's my sleep talk. Mood symptoms, that's the last in the trifecta of significant things we see in menopause that I'm going to talk about. Both depression and anxiety, we see increases in through perimenopause and menopause. And it's not that there are these windows of vulnerability in our lives as women, happens around the time of puberty with the hormone changes, happens postpartum anxiety and depression, and happens around menopause. A history of anxiety or depression is certainly the biggest risk factor for developing perimenopausal depression or anxiety, but there are other things that increase the risk of symptoms. Lack of sleep, life stresses, having a chronic disease, having worse vasomotor symptoms, worse hot flashes and night sweats is associated with a higher risk of menopausal depression and anxiety. Poverty is a risk factor. To women who have depression and anxiety, especially if it's worsening through perimenopause, you are not alone. Clinical depression is 2 to 4 times more common in perimenopausal to early menopausal women, and there is a surge in anxiety in some women around the time of menopause. There are excellent treatment options. Proven interventions for depression and in many cases for anxiety are SSRI or SNRI and other medications. We know therapy, including cognitive behavioral therapy, is very effective. Many people can access therapy through their workplace if there's a program. Through mental health, there's the One at a Time program for people who are struggling to access single episode or periodic therapy. And there are other lifestyle interventions. We've talked about some of those as being add-ons, things like exercise and stress management. But for women who are really struggling with a significant clinical depression or anxiety, I never recommend exercise and yoga as your only management for that. Although depression is not an approved indication for menopausal hormone therapy, so we wouldn't put someone on hormones only because of depression in menopause. Depressive symptoms may improve with hormone therapy in some women. So hormones can certainly be used as an add-on strategy for women for whom the main symptom is depression. For women who are experiencing depression along with a lot of other vasomotor symptoms, then certainly hormone therapy can be considered in that case. And here's my most important diagram in talking about moods. If you're 45 to 55, you are here. And although this happens to be data from women in the UK, this diagram of happiness versus what your age is has been replicated across various cultures and populations of women around the world. And we know our life stresses as well as depression are at their worst at around 45 to 55, but then they continue to improve once you get further away from menopause. That doesn't mean don't treat your symptoms now, don't treat your mental health problems and struggles now, but it does mean that over time, these symptoms do tend to improve. I saw a great talk a couple of years ago where the presenter who specializes in perimenopausal psychiatry said, like, there's no one on earth happier than the 60-year-old woman. So if we can get through this, it will continue to get better. I'm going to move on from those big things to some of the other things. So the genital urinary, meaning genital, bladder, and sexual changes. So in terms of the genital urinary changes we see in menopause, so the vagina, the vulva, the bladder, that whole area, the vulva, vagina, bladder, are full of estrogen receptors. Estrogen stimulates fancy things like collagen, hyaluronic acid, and mucopolysaccharides, which are basically just things that help the vagina and the vulva, the skin area, to be healthy. So when we lose estrogen, there's a thinning. So this is what it looks like normally in a premenopausal woman and after menopause. So there's thinning of the skin, there's loss of some of the contour, there's less blood flow, there's less of the lactobacilli. Those are the nice healthy bacteria that keep the vagina a healthy place, keep the pH normal. There's some narrowing of the vagina and also decreased sensitivity over time. The term is genital urinary or genital syndrome of menopause, referring to all those symptoms we can see. So half of women will get symptoms like vulvar dryness, itching, burning, irritation, vulvar dryness, itching, burning, discharge. I said those out of order, but you know what I mean. The vagina, the vulva, it can be a dry, irritated, unhappy place. Bladder symptoms, so burning with peeing, sometimes frequency. Sometimes women get a lot of symptoms like they have a bladder infection, but then their urine culture is normal, so it's not an infection, it's lack of estrogen. But for some women with the lack of estrogen, they are more prone to bladder infections through menopause. In terms of sexual symptoms, the result of a lot of that is there's decreased lubrication. Sometimes there's increased pain with intercourse. There can be more difficulty achieving orgasm, either a decreased intensity or delay in reaching orgasm, sometimes bleeding because of the thinning in the skin. My only side note to the bleeding, though, is any woman who has bleeding bleeding more than 12 months after not having any periods should be investigated to make sure there's not something wrong. In terms of how we manage this, I'm actually going to start with the non-prescription stuff first. So for women who have a sensation of dryness, they can use over-the-counter moisturizers. These are non-hormonal things with fancy names like Gynatrof and Replens and Zestica that can be used regularly in the vagina to help restore some of the moisture to the skin or the epithelial lining there. For sex, vaginal moisturizers aren't adequate for sex. Over the counter, if you want to buy a specific lubricant, there are both water and silicone-based lubricants. I usually advise women against water-based lubricants unless they need to be compatible with condoms, because water-based lubricants, they dry out and they become quite tacky. So you can actually get more microtrauma in the skin as the lube dries out and gets kind of sticky. My favorite that I recommend to women are solid vegetable edible oils. Not like edible oil product that you see in baked goods, but things like coconut oil, vegetable shortening. Crisco is sort of the classic. And I know that sounds really weird, but we know that coconut oil, Crisco are made with no artificial flavors or colors, no weird preservatives. They're cheap. You can buy them over the counter. You don't need to tell anyone what you're buying them for. They may stain the towel underneath, so like make sure you aren't just using your sheets if you're using a solid oil. And they have lasting power and stay slippy for a really long time. The only thing is they're not safe with condoms. So if you're someone who has to be using condoms, then you need a water or a silicone-based lubricant. And this is where I added my reminder that age doesn't protect you from chlamydia. So if you have a new sexual partner, until you both get tested, use condoms, and with the condoms, use water or preferably a silicone-based lubricant. There are other interventions that can be helpful for the genital syndrome of menopause that are non-prescription. So the clitoris gets decreased sensation to touch over time, but it actually retains its sensation to vibration for a very long time after menopause. So vibration can be really helpful for that. Vaginal dilators, and they can be used alone potentially, but also in conjunction with a pelvic physiotherapist if there's a sense of narrowing or tightness or muscle tension in the vagina or the pelvic floor. Fredericton is a hotbed of pelvic floor physiotherapy. A number of years ago now, Lynn Sweeney, who's one of our pelvic floor physios in Fredericton, came and actually presented to the Atlantic Society of Obstetricians and Gynecologists. So she came to our big annual meeting and spoke to a huge group about pelvic floor physiotherapy and its uses. She's one of the godmothers of pelvic physio in Atlantic Canada. But working along with her, we have a bunch of other pelvic physios in Fredericton who have excellent training. Many of them work with Lynn, and they provide excellent care. So if you have issues with discomfort relating to things feeling tight or narrowed, pelvic physio is another resource. Laser is a bit more controversial. It has a black box warning on it with the recommendation that it be in research studies at this point in time. If a woman goes through the routine things, or there's suggestions on here and is still having symptoms that aren't improving, then they need an exam with a physician or a nurse practitioner to look for other causes of their symptoms. So skin changes that can happen, for example, that may need different kinds of treatment. In terms of prescription therapy, the main one we think of is estrogen. So we talked earlier about systemic estrogen, meaning you put it on your skin or take it by mouth and it goes through your whole system. Vaginal estrogen acts just locally in the vagina. It doesn't hit your bloodstream in any meaningful way. So it's ultra low dose what we use. It can come as a cream, as a tablet, as an ovule. Most women use it daily for a couple of weeks to start, but then kind of twice a week for maintenance. Vaginal estrogen is safe in basically all women except for those who are on really specific breast cancer medications meant to drive their estrogen level down even lower than what we normally see after menopause. So pretty much all women, even women who have a history of blood clots or heart disease, can use vaginal estrogen. For women who have pain with sex that doesn't improve with just vaginal estrogen, there are a couple of other options. There's a vaginal DHEA called Prasterone. It's a prescription that's used every night. It can cause some vaginal discharge, but my experience is for women who don't have great improvement with vaginal estrogen, that's a really effective one specifically for pain with sex. And that's probably because it hits both estrogen and testosterone receptors on the vulva a bit. There's an oral pill, a SERM type medication called ospemifene. That's a daily pill that women can take that can help with bone, but may worsen hot flashes, but also can be helpful for pain with sex, specifically in menopause. And I'm going to segue here a little bit to low libido and the fact that in menopause, we often don't feel very sexy. I'm including this orangutan picture, and there may be one person here laughing because I saw a patient last week and she said, "Do you know what I feel like?" And I said, no, what do you feel like? And she said, I feel like when you go to the zoo and you see the orangutans and their boobs are hanging down and they got the big belly, that's how sexy I feel these days. And we had a really good laugh about it. And I said, I might need to use that in my presentation next week. And she said, please, absolutely, go for it. So I can't take credit for putting the orangutan picture up because it was someone else who gave me the idea. But it's common for us to feel a bit like this, right? There are lots of reasons for libido to change through perimenopause and menopause. All of those menopause symptoms often negatively affect sexual desire. She's not feeling sexy at all right now. Between the hot flashes, the night sweats, the sleeping trouble, the no energy, the weight gain, and the distribution with a spare tire in the midsection, the mood swings, and the irritability, the irritability, and also the fact that pain or that sex can be painful and there's less lubrication. There are many reasons for women to not feel a lot of sexual interest around perimenopause and menopause. And I talked to him about sort of the libido box in your brain. It's like we have a box in our brain that says, is this a good time to get pregnant or not? And part of the reason why that box exists is to protect us, right? Because women bear the brunt of pregnancy and childbearing. Men, the box in their brain more often says, yes, of course it's a good time to get pregnant because their evolutionary drive is to spread genetic material. For women, where we're the ones who have to live through the pregnancy, deliver, and then raise the children, the box in your brain says, is this a good time? Do you have enough physical, emotional, mental resources? Are you in a good place in terms of your stress management and your relationship? And if you're in a good place, the box in your brain says, yeah, let's go for it. Because the box in your brain doesn't know that you don't have any eggs left in your perimenopausal or menopausal. The box in your brain doesn't know he had a vasectomy. It just knows, should we get pregnant or not? So if everything's good, the box in your brain says, sure, let's go for it. But if the box in your brain says, are you crazy? It is going to shut that down. And so most decreased libido is situational. There is sometimes a role for medical treatment of low libido when everything else has been managed. For women who have true hypoactive sexual desire disorder, it's off-label, but certainly a recognized treatment. That's a little beyond this talk, but that is applicable in some situations. And I think the last thing I'm going to chat about is the cognitive changes. It seems awfully foggy in here, and that's because there's lots of cognitive changes through menopause. Many women are worried about cognitive decline, but cognitive function actually declines really gradually over time. Most of it is age-related and not hormone-related, although we feel like our brain is being eaten. So I got Canva, which is like an app for making diagrams. That's what I use to make all the graphics in this presentation. And you can search for images, and my search for images was like menopause brain fog, and this was one of the images that came up. So I know it feels like this is what's happening to our brains. I promise it's not. But there are some actual measurable changes in our brains during perimenopause. I don't need to tell you that if you're in this presentation. You probably are very well aware of that. But particularly word finding difficulties, I find this very challenging when I'm presenting. I have more word finding difficulties. Memory, working memory, recall memory for stuff, concentration. Those are particularly impaired through perimenopause. But in terms of what's not affected, our ability to learn new information and respond to information is actually the least effective. So if you wonder why there are so many really amazing 50-year-old female prime ministers around the world, it's because they can still learn new stuff. They can still process information and make fantastic decisions. We know that all of those cognitive changes through menopause are worse if you're experiencing other symptoms with them: depression, anxiety, sleep disturbance, and again, worse vasomotor symptoms, worse hot flashes and night sweats. All of those things make all of those brain fog type symptoms even worse. In good news, the main perimenopausal brain fog things, the word finding, the memory, the concentration, those actually appear to be transient or short term. They seem to last through perimenopause, and they appear to resolve after menopause as the hot flashes are resolving. So that part resolves, but our cognitive function continues to decline over time, which is why it's important to do activities to help put your breast brain forward. Pauline Mackey, fantastic menopause brain specialist in Chicago. I saw her speak last year, and she was really cool. But she came out with this fantastic paper all about what are things women should be doing to look after their brain through menopause. I came up with this diagram, but I used all of her suggestions from her paper. And there's 6 core recommendations. One is don't smoke. So if you smoke, quit. Or cut back as best as you can. Use nicotine replacement if you need to. The second one is to exercise your brain, things to keep your brain busy. For many people, that's continuing to work. If you're not working, that means being engaged in things, volunteering, continuing to interact with people, keeping your brain active with activities and puzzles and games and things, staying connected with others socially. We're seeing some themes here, right? I keep talking about stay connected with people as being good for so many things, and it's also really good for your brain. Training your body to boost the brain means staying active or regular exercise helps to slow cognitive decline over time. Trying to slow that midlife weight gain as much as possible, that doesn't mean trying to lose weight. We know women and everybody will progressively gain some weight over time. Staying the same weight or gaining slowly is considered a win in terms of that from that regards. And finally, heart health is brain health. What that means is the same risk factors we see for heart disease, heart attacks, things like high blood pressure, high cholesterol, diabetes. Those are things that also can factor in brain health. So making sure you're optimizing, managing your blood sugars aggressively. If you happen to be diabetic, control your blood pressure, control your lipids. So those are your 6 big things that you can do to help keep your brain healthy. Okay, that was really long. It went longer than I thought because I tried to talk slow. I know I was really fast still. I'm really sorry. But my summary on this is that menopause symptoms can be really disruptive. You are not going through this alone. Looking at the interest in this presentation tonight, there are many, many, many options that can help you manage your symptoms that I went through a bunch of tonight. And it's okay to look after yourself. It's important to look after yourself. You deserve to look after yourself going through all of this. And if you're not having a lot of symptoms, that's amazing too. But the other healthy habits are still important, right? Good nutrition is still important. In terms of action items, this is my last yellow do this box, I promise. Consider your intake of vitamin D, calcium, magnesium, and protein. Do one thing this week that helps you manage stress, like getting into nature. If you're due for one, book a mammogram and a pap test. Plan to incorporate healthy habits into your life, exercise, sleep, staying connected with people, and access resources that you know are reliable to learn more. And this is I'm going to go to the thank you slide and then come back and leave this slide up. This is those resources that I list. So the Menopause Quick 6, menopauseinyou.ca, CanadianMenopauseSociety.org under the For Women section, menopause.org under the Patient Education section, and mysleepwell.ca. There. I know that was a lot of information packed in. Thanks for bearing with it all.
And thank you for taking the time to repeat this. I reiterate that with the volume of people that responded to this suggest that we are all in need of credible information. And it's so nice to have somebody close to us that cares about us and about our health, and that helps us have the tools to do the same for ourselves as individuals and for our loved ones. So thank you for taking your time as well. The last thing I will say is just, I think the other piece you gave me is hope. And that is hope that we are talking about this more, and you're, I think, dispelling some of the old myths that I know my mother and aunts and grandmothers would have passed on related to breast cancer and heart health and all those sorts of things. So it's nice to have the context and the background to understanding why those stories ever came out in the first place.
Yes, thanks. I do have one last ask, which is riot, riot, riot for primary care reform and access. It is such a huge need, not just in New Brunswick, but across this whole country, but particularly in New Brunswick. I think our government is trying to take good steps, but keep putting pressure on, because I agree everybody should have someone they can go to who either listens to them, or if they say, I have no idea what to do with this, who can refer them on to somebody else. I am one person in a city, but I know there are lots of very competent people who can do hormone stuff in Fredericton.
Great. Thank you. Any last words, Amanda?
Thanks, Christa. You're amazing. Dr. Mullaly.
Thanks very much, everybody. Have a great night. Thank you so much for joining.
Thanks for coming. Bye-bye.